अरे मारी मीटिंग चेक झूम मीटिंग.
तर वर्षा कुराडे मॅडम आणि साळगावकर मॅडम जॉईन झाल्यात, त्यांना को होस्ट करा प्लीज.
ऍक्च्युली वर्षा कुराडे मॅम होत्या पण त्यांनी लेफ्ट केलं वाटतं. आणि हा आल्या जॉईन झाल्या
बॅक.
येस येस.
There are some internet issues actually, but we are ready now with 2 devices.
मॅम मग दोन्हीला को होस्ट करायचंय का तुम्हाला?
हो, जे
केअरला पण
दिसतंय ना, हा या तेच माझं सांगणं होतं. आपण करून ठेवा. इकडे काही क्रॅश झालं तर मी तिकडे स्विच ओव्हर होता येईल.
डागा सर के केअर हॉस्पिटलला पण करा को होस्ट.
Can you get there in time? We're on it. Rescue bots, all to the rescue.
आणि आपले जे इथे होस्ट असतील ना, त्यांनी सगळ्यांना म्यूट करायचं सेटिंग ठेवा अनलेस यू अलाउ. तर नाहीतर ना मध्ये मध्ये खूप डिस्टर्बन्सेस येतात. ऑडियन्स ना ऑडियन्स कांट हिअर प्रॉपरली असं होतं.
बोरसे सरांना फोन केलाय का? जॉईन नाही झाले आणखीन.
मॅडम मी जॉईन झालेलो आहे.
ओके, वेलकम सर.
या
बोरसे सर, तुम्ही नंबरनी जॉईन झाला आहात का? नाव दिसत नाहीये.
हो, ऍक्च्युली आता बोलले ते तेव्हा त्या नंबरनीच त्याच ह्याच्यावरून आलं होतं त्यांचा.
मॅडम येतोय का? माझा आवाज येतोय का?
हो, येतोय येतोय.
व्हिडिओ बंद आहे, ऑडिओ चालू आहे.
हो हो,
तुम्हीच
चालेल.
बंद केलाय ना तिकडून. व्हिडिओ पण ओपन झाला बघा.
के केअर हॉस्पिटलला पण को होस्ट करा.
प्रेरणा, आवाज येतोय ऐकू?
हो, येतोय.
हा, डागा सरांना को होस्ट कर आणि सरांना, बोरसे सरांना को होस्ट कर. तुला
अच्छा.
होस्ट केले सरांनी. हा.
अच्छा. डागा सरांचा हा आहे. जाधव सर झाले का join?
नाही रे.
पोचके सर झालेत का जॉईन? जाधव सर झालेत का जॉईन?
नाही झालेले, मी करते फोन.
आणि डॉक्टर नाना पोचके?
नाही, बहुतेक नाही.
Excuse me. हेलो
हाँ,
सर, मीटिंग स्टार्ट करवाइए मैम.
मीटिंग एक जस्ट 5 मिनिटात सुरू होतीये.
जी मैम.
सुहास जाधव सर जॉईन झाले का नाही?
सर झालेत जॉईन, दिसतायत मला.
Good afternoon, everybody.
Good afternoon, sir.
गुड आफ्टरनून सर.
गुड आफ्टरनून सर.
Good afternoon, everybody.
गुड आफ्टरनून.
Good afternoon. Yes. पाहुणे सर यायचेत का अजून?
हा सर, नमस्ते सर.
नमस्ते पाहुणे.
चालू करूया सर मीटिंग. आलेत बऱ्यापैकी.
हो,
68 आहेत.
चालेल.
नाना पोचगे सर जॉईन झाले नाहीत बहुतेक.
सर पोचके सर पोचका.
सरांना फोन करतो मी. सर जॉईन हो ना. जॉईन होऊन टाका सर लगेच. हा, सुरू होत आहे आता. या तुम्ही.
जाधव सर सुरू करायचं?
हा, पोचगे सर येत आहेत. 1 मिनिट फक्त.
ओके ओके.
जॉईन झालं ना? हाच नंबर आहे ना? हो पाठवले ना. तुम्ही नाही बघितलं? परत पाठवू? ग्रुपवर पण वैयक्तिक पण पाठवली सर. परत एकदा पाठवतो मी. लिंक पाठवा नानांना. नाही लगेच दे, पाठवून दे लगेच. बर पाठवून दे. बर ठीक आहे, पाठवून दे.
हॅलो
हॅलो
सर, नमस्कार. दागा बोलतो.
हा बोला गिरीशजी बोला.
काही नाही नाना, हे पोचगे सर नाही आहे जॉईन का अजून?
हो जॉईन होत आहेत लगेच. होत आहेत ते लगेच. होत आहे. बोललो आताच बोललो मी.
ओके ओके.
होत आहे.
प्रेरणा मॅडम, अजून कोणाला कोहोस्ट करायचं आहे का?
चेक करते. एवढं सफिशियंट आहे.
पाठवली.
नाही सर.
बरोबर जॉईन व्हा लगेच प्लीज.
आजारे सर नाही आहे ना? All the participants will be remain muted for all the complete session. Those who want to speak, they can raise their hand. The host will allow you to speak. Otherwise, all the co-hosts can unmute themselves from their point. All the co-hosts can unmute themselves from their end, and other participant, if they want to speak, they can raise their hand, and the host will be allow you to talk. Thank you.
डागा सर, नाना पोचगे सर आणि डॉक्टर नरेंद्र कसबे सर यांना पण को होस्ट करावं लागेल.
ओके, झाले का जॉईन नाना? हा झाले.
सर सुरू करायचं?
अजून कोण बोलले? नानांना केलंय. नरेंद्र कसबे सर.
सर मी झालो जॉईन.
हा कौस्तुभ सर झाले. येस येस
सर मी जॉईन झालोय.
ओके ओके नरेंद्र राईट.
जाधव सर सुरू करायचं.
म्यूट केला. सुरू करा मॅडम प्लीज.
ओके सर.
हॅलो.
Good afternoon, all NIMAites. Myself, Dr. Prerna Berry Kalekar, Member, Cultural Committee, Amrutmohotsav, MSB. Welcome you all enthusiastic participants for Jnana Yajna Webinar Series 10th session organized by NIMA Maharashtra State Branch. I welcome all dignitaries of NIMA Central, President Dr. Vinayak Tembhurnikar sir, Treasurer Dr. Ashutosh Kulkarni sir, NIMA Central Women's Forum Dr. Sadhana Kulkarni ma'am, Dr. Masodkar ma'am, NIMA Maharashtra President Dr. Suhas Jadhav sir, Secretary Dr. Anil Bazare sir, Treasurer Dr. Bhushan Wani sir, NIMA Women's Forum State PST, all Executive Committee members, coordinators for Jnana Yajna Webinar Series, Dr. Vishnu Bhavne sir and Dr. Padmanabh Keskar sir. Dr. Nana Pozge sir, Vice President Nagpur, Dr. Narendra Kasbe sir, Secretary Nanded. I welcome today's speaker, Dr. Varsha Kurhade ma'am, Chairperson Dr. Sweta Salgaonkar, Co-Chairperson Dr. Nandakishore Borse sir. At the outset, I congratulate all NIMA members for the beginning of Platinum Jubilee year and a grand successful function of NIMA Amrutmohotsav at PCMC. Today's webinar topic is very important. As it is said, pain is inevitable part of life. So its management is the need of era. And we have got a very eminent consultant, Dr. Varsha Kurhade ma'am, to deliver this useful session on chronic pain management. Now I invite Dr. Nana Pozge sir, NIMA MSB Vice President Nagpur, to deliver his speech on behalf of NIMA Maharashtra State. Dr. Pozge sir, please. सर अनम्यूट करा. सर अनम्यूट करा तुम्हाला स्वतःला. अनम्यूट युअर सेल्फ सर.
नानाजी अनम्यूट करा आणि बोला.
पोचगे सर तिथे छोटासा स्विच असेल म्यूट म्हणून.
आलाय आता झालाय.
येस
झाला येत आहे आवाज येत.
बरोबर. नमस्कार सर्व निमा मेंबर आणि सर्व पदाधिकारी. आपणा सर्वांना 75व्या वर्धापन निमा 75व्या वर्धापन दिनानिमित्त शुभेच्छा. आपण हे 75 वर्ष साजरं करतो आहे आणि संघटनेच्या दृष्टिकोनातून हे अतिशय महत्त्वाचं आहे. कारण आजपर्यंत संघटनेने BMS आणि सगळं आयुष डॉक्टर युनानी यांच्यासाठी जे संघटनेने काम केलं त्या कामाचा आढावा आणि आजपर्यंत ज्या जे आपले ज्यांनी या संघटनेची नीव रोवली आणि संघटना ही निर्माण करून BMS आणि युनानी डॉक्टरांना न्याय मिळवून देण्यासाठी आजपर्यंत जे काही त्यांनी उपक्रम राबवले, संघटनेची एकता कायम ठेवली आणि अशी करता करता हे छोटंसं रोपटं त्यांनी मोठं केलं. आज आपण 75 वर्ष साजरा करताना आपण सगळे विषय घेतो आहे. संघटनेचे ज्या काही ब्रँच आहेत त्या ब्रँचेस आपल्या परीने संघटनेची जनजागृती करणे, तसेच सामाजिक चळवळ निर्माण करणे आणि समाजासाठी एक असं सेवाभावी कार्य आपण करतो आहे. आमच्या संघटनेचे अध्यक्ष, नॅशनलचे अध्यक्ष टेंभुर्णीकर सर आणि सेंट्रल निमा, तसेच महाराष्ट्र निमा पदाधिकारी, अध्यक्ष, सेक्रेटरी आणि कोषाध्यक्ष आणि पूर्ण टीम जे अथक प्रयत्न घेत आहे. आता जवळजवळ 13 एप्रिल पासून आपण या कार्याला सुरुवात केली आहे. आणि हे कार्य करत असताना ज्यांनी आपले मुळाचा वेळ संघटनेला दिलेला आहे, संघटनेने आणि संघटना एकत्रित ठेवण्यासाठी आज जे कार्य करत आहे त्या सर्वांचं मी निमा महाराष्ट्र निमातर्फे अभिनंदन करतो, आभार मानतो. तसेच ज्यांनी आपलं आयुष्य या संघटनेला 30 वर्षापासून, जवळजवळ 40 वर्षापासून, काही लोक 75 वर्षापासून या संघटनेचं काम करत आहे. आज काही लोक आता त्यांनी जे काम केलं आहे त्यांच्याही कार्याचा गुणगौरव व्हावा आणि जी लोक आज आपलं पूर्ण सर्वस्व संघटनेसाठी देत आहे त्यांचा आवर्जून अशा लोकांचा सन्मान व्हावा, त्यांचा रिस्पेक्ट व्हावा. संघटनेसाठी जे आपले तळागाळातले कार्यकर्ते आहेत ते पण संघटनेसाठी काम करत आहे, त्यांचा पण आदर करण्यात यावा. संघटनेने आपापल्या ब्रँचमध्ये त्या संघटनेने त्यांना आवर्जून हायलाईट करून त्यांनी संघटनेसाठी काय कार्य केलं, कशा प्रकारची त्यांची कार्याची पद्धत आहे, समाजसेवा करणे, तसेच संघटना वाढीसाठी मेंबरशिप तयार करणे, यासाठी जे प्रयत्न करत आहे आणि संघटना वाढीसाठी जो प्रयत्न करत आहे, तसेच नव्या लोकांनी संघटनेमध्ये सहभाग घेऊन संघटनेला मोठं करायचं काम त्यांनी ही धुरा वाहण्यासाठी मला असं वाटते का त्यांनी पुढे यावं आणि संघटना ही अविरत कार्यरत राहावी. आणि आमच्यासारख्या अजून सिनियर लोकांना थोडा आपला लोभ लालच सोडून थोडंसं मागे येऊन अशा नवीन लोकांना, होतकरू लोकांना समोर करावं आणि त्यांच्या सगळ्या ॲक्टिव्हिटी त्यांना इंटरेस्ट तयार करण्यासाठी त्यांना मार्गदर्शन करावं आणि त्यांना समोर करून संघटनेची तरुण संघटना कशी होईल, त्या संघटनेत तरुण लोक कसे इन्व्हॉल्व होतील आणि त्यासाठी त्यांचा जो इंटरेस्ट त्यांना आहे आणि ते आपला वेळ देऊ शकतात अशा लोकांना आपण मोटिवेट करायला पाहिजे. आणि असं मला तरी वाटतं. आज मला या ठिकाणी आपण मला बोलण्याची संधी दिली संघटनेच्या दृष्टिकोनातून आणि संघटना जी आता आज जे कार्य करत आहे, आता जे हे मोठे वेबिनार चालू आहे, मोठे कार्य झाले, नागपूरला सुरुवात झाली आणि मी भुसरी पुण्याला पण सुंदर त्यांनी अशा प्रकारचं आयोजन केलं, इतक्या लोकांची व्यवस्था केली, मोठ्या प्रमाणात त्याला प्रसिद्धी मिळवून दिली. निमा संघटनेचं नाव हे पूर्ण भारतभर पोहोचवण्याचं काम पिंपरी चिंचवड ब्रँचने केलेलं आहे. आणि त्यामध्ये मोठा सहभाग जे आपले संघटनेचे जे अध्यक्ष आहेत, जे संघटनेचे प्रसिद्धी प्रमुख आहेत, यांचा फार मोठा त्यामध्ये सहभाग आहे. आणि त्यांना तो अभ्यासपूर्वक ह्या संघटनेची माहिती देणे आणि संघटनेला स्ट्रॉंग कसं ठेवायचं, मजबूत कसं ठेवायचं आणि आपली संघटना ही निमा संघटना अविरत कार्यरत आहे. आणि आज आपण आपल्या ज्या संघटनेच्या काही मागण्या आहेत त्या महाराष्ट्र सरकारपर्यंत तसेच केंद्र सरकारपर्यंत कुठलंही राजकीय यामध्ये भेदभाव न ठेवता आपण ते प्रयत्न करतो आहे, ही फार संघटनेची ही फार मोठी उपलब्धी आहे. आपल्या संघटनेमध्ये अनेक पक्षाचे लोक आहेत, अनेक विचाराचे लोक आहेत, पण आपण संघटनेसाठी मला असं वाटते इथे कुठल्याही प्रकारे संघटनेमध्ये हा वाद येऊ न देता संघटनेचा महत्वाचा दृष्टिकोन ठेवून आणि BAMS स्नातकांचं तसंच युनानी स्नातकांच्या ज्या समस्या आहे त्या कॉलेज लेवलवर असो, जनरल प्रॅक्टिसवर असो, मेडिकल ऑफिसर असो, यामध्ये संघटना ही फार मजबूतीनं कार्य करत आहे आणि याची फळं ही आपल्याला ताबडतोब मिळतील असं मला वाटते. आणि म्हणून मी आपल्या संघटनेच्या वतीने सगळ्या सदस्याचे, आमच्या सगळ्या पदाधिकाऱ्यांचे मी आभार व्यक्त करतो, त्यांना धन्यवाद देतो आणि महाराष्ट्र निमातर्फे मला जे आपण बोलण्याची, माझे विचार मांडण्याची मला संधी दिली त्याबद्दल मी संघटनेचा आभारी आहे आणि माझे लांबलेले 2 शब्द इथेच थांबवतो. धन्यवाद. जय हिंद, जय भारत, जय निमा.
Thank you so much, Nana Posge sir, for your guidance. Today, we have a very eminent chairperson, Dr. Shweta Salgaonkar ma'am, Professor Anesthesia, Pain Consultant, SET, GSMC and KM Hospital, Mumbai. Ma'am is in charge Anesthesia, Maxillofacial Reconstructive Vascular Surgery, Consultant Pain Physician offering interventional pain procedures, Fellow of Indian Academy of Pain Medicine, Secretary ISA Mumbai Metro, Associate Editor of Journal of Postgraduate Medicine, Postgraduate Teacher and Examiner for Anesthesia for Mumbai University and MUHS, winner of Dr. Amrutmohotsav Award GSMC Mumbai. She believes in pain relief is basic human right. Welcome, ma'am. Today, we have got a very senior surgeon as co-chairperson, Dr. Nandakishore Borse sir, HOD, Department of Shalyatantra, Tilak Ayurved Mahavidyalay, Pune. His honorary surgeons at Tarachand Hospital, Pune, ex-president NIMA Pune, President Association of Anesthetists of Indian Medicine. Sir has a vast experience in teaching for more than 30 years, teaching UG, PG and guiding PhD students. He has worked as external and internal examiner in Pune University and MUHS, presented many papers on national and international platform. Most welcome, sir.
Thank you, madam.
I request co-chairperson Dr. Nandakishore Borse sir to introduce our today's speaker, Dr. Varsha Kurade ma'am.
Thank you, madam. Good afternoon, everyone. First of all, I am grateful to the NIMA MSB branch who organized this webinar. I want to thank them for inviting me as a co-chairperson. I appreciate the organizer for arranging the webinar on chronic pain, such as important topic to be discussed. Pain is very crucial factor in every human body. That's why it is necessary to update everybody knowledgeable about chronic pain management. Now, it is my great privilege to introduce today's guest speaker, Dr. Varsha Kurade. Dr. Varsha Kurade completed her MBBS diploma in anesthesia DNB from MUHS and working as a pain management consultant. Also, she is a director of and program head of pain and KK multi-specialty hospital at Alandi, Pune. She is also handling the responsibility and of head of pain and palliative care of Indira Hospital in Alandi. She is serving as a secretary at Society for Study of Pain, co-editor and EC member of Pimpri-Chinchwad Society of Anesthesiologists. She has awarded and fellowship by Indian Academy of Pain Medicine, MHS accredited fellowship in palliative care from Cipla Cancer Institute, Pune. She has published more than 10 research papers. She has presented in many state and international level faculty conference. She has been honored by many awarded fellowship by of few of them are Lokmat Woman Achievement Award, Rotary Award, etc. Now I request Dr. Varsha Kurade to share her knowledge and thoughts about the topic of pain management. Thank you very much.
Thank you so much, Borse sir, for such a warm welcome.
Thank you,
I
madam.
would like to thank Dr. Suhas Jadhav, President NIMA, Dr. Prerna Kalekar ma'am, who is my old friend and we know each other since quite a few years. So happy to see her. And most importantly, giving me the opportunity to share this platform with you all and my mentor and my guide in this field, Dr. Shweta Salgaonkar. So with your permission, should I start presentation now?
Yeah, madam. Yes.
Okay. So I'm sharing the screen. Hope it is visible.
Yeah.
Okay. So chronic pain management. As sir has rightly said, this has become a new disease of this world. We all are aware of epidemic term. Epidemic means something which does exist all the time at particular place. So pain is now silent epidemic of this world, we can say. Why this specialty is so important? Why we are coming up with different branch, or we are speaking about pain and palliative care as emerging specialty. If we see point prevalence, means at any point of moment, 13 patients out of 100 are suffering from the chronic pain. Out of them, 37 to 63% has got moderate to severe pain, quite great intensity. If we see specifically at problems like knee pain, 32% of all chronic pains are knee pain. So this data itself gives us the depth of this problem. And we are just looking at the tip of the iceberg in our clinical practice. 1 in 4 individuals over the age of 60 develops knee pain. With increasing life expectancy, chronic pain becomes an ever-growing problem. Apart from that, we do manage acute pains like in cancer pain, post-surgery pain, or during rehabilitation phases. So as sir has rightly said, pain clinic is the need of an hour. As I was saying, the depth of problem. This has been recently, I found in one of the article in last year. All chronic diseases, when they charted the percentage of diseases, they found arthritis was existent in 15% of the population. We can see diabetes, cancer, COPD, asthma, cardiovascular diseases. They have the burden of almost 25 to 30%. But arthritis, back pain and problems, and mental health condition, these 3 problems constitute almost 50 to 60% of the burden. And that's the reason we have to look at it, and we are the person, especially when it comes to members like NIMA. I really appreciate the contribution and all NIMA members to be first point of contact for such patients. So why is pain so common? We all know nowadays changing lifestyle, sedentary life habits, wrong postures, long sitting hours like IT professions, increased life expectancy because of advanced medical techniques and researches and medicines availability. Most of the diseases are we are able to keep under control without going to the level of mortality. But definitely that is adding to burden or morbidity, what we call is because of increased life expectancy. So which patients do we call as chronic pain patients? We all know many a times we get patients saying, बॅक पेन होत आहे, 4 दिवस झाले, थोडं गुडघा मुरगळला किंवा टाचेला अचानक खड्ड्यात पाय गेल्यामुळे झटका बसला. So something like this, quite common in day-to-day practice, sprains and pains. This is acute pain. But when any pain that persists in any part of the body for more than 3 months, and where we really don't have any acute cause, like cancer, appendix, or any obvious visible pathology, this becomes part of chronic pain specialty. These patients usually not respond to standard treatment, which we all regularly prescribe. Then pains associated with untreatable causes like cancer pain, degenerative arthritis, diabetic neuropathy, post-herpetic neuralgia lasting for years altogether. So these are the patients which we often found in chronic pain patient OPD. Why should we treat chronic pains? Patient keeps coming repeatedly. We keep giving medicines and drugs. They have temporary relief, or sometimes they have good relief. It is recurring. Sometimes they don't get relief. We keep escalating the doses or keep adding more, stronger analgesics. So, but all these drugs, when pain relief is not there, as we can see, we call it as vicious pain cycle. When pain is not controlled, there is muscle guarding, like in back pain. The compensatory paraspinal muscle try to get spine in normal alignment so that it doesn't move and give the patient pain. So giving rise to muscle spasm, inflammation, and that tightness, stiffness leads to restricted movement. We very often we see in the practice that patient comes with the lumbar belt, cervical belt. हे डॉक्टरांनी दिले आणि सांगितलं बिलकुल हलायचं नाही आणि हे दिवसभर घालून बसायचं. But that restricted movement, it gives pain relief, no doubt. It is very simple. When movement is causing pain, we immobilize the area and there is no pain. But then that leads to muscle weakness and loss of normal function over the period of prolonged, duration. And that leads to psychological upsets and problems like anger, frustration, helplessness. When regular movements or regular activity, day-to-day course are not possible, it is ought to happen that our psychological functions are also disturbed. I would like to pay attention, draw your attention to this very common and routine problem like myofascial pain syndrome. This kind of entities are very commonly, every other patient is coming with some kinds of pain, more or less associated with myofascial pain syndrome. Myo is muscle, fascia is covering over the muscle. So, जसं की या डायग्राम मध्ये दिसतंय, wherever we have got muscle and fascia, there is possibility of myofascial pain syndrome. Again, nowadays more common in the neck and upper back because of mobile use, excessive computer use, and our lifestyle changes. So this is the reason of the myofascial pain syndrome. And we often find trigger point, patient can localize the pain. Ha, तिथे तो एक point खूप दुखतोय. And then slowly we get the referral pattern of trigger points as indicated by dots here. And slowly pain starts spreading and it becomes chronic pain syndrome. As we can see, again, this is another vicious cycle, especially related to joint pain. So because of defective posture, habits like wearing high heels in the woman, weight gain, all these things leads to loading of spine and joints, which can give rise to pains like knee pain, back pain, ankle pain. So when we have pain, when patient comes with the pain, obviously they can't exercise. And to compensate the pain, there is physiological antagonist development of the muscles. And we adapt faulty posture unknowingly so as not to have pain. And again, because of defective posture, because of immobilization, because of not able to exercise, again, it leads to weight gain. So this is the vicious cycle nowadays in this era because of sedentary lifestyle, obesity, and diabetic diseases like diabetes, which are prone to weight gain. These are seen very rampant. So joint pain are seen in the conditions like frozen shoulder, painful shoulder, maybe due to any acute causes like females comes, आता दिवाळी होती, नवरात्र होती, जरा घर झाडून काढलं, खूप कपडे काढले धुवायला आणि shoulder pain चालू झाला. Then rotator cuff injury. Rotator cuff injury, when they come for rehabilitation, maybe before surgery or post surgery, they have a lot of pain. Degenerative arthritis in the joints like hip and knee, osteoarthritis, knee or ankle. Then post TKR pain, we are always under the impression that total knee replacement, when we replace the joint, that time pain should vanish. But almost 20 to 30% of patients undergoing replacement have this pain even after surgery and good functional rehabilitation. So these are kind of neuropathic pain, which we have to address differently and in a multimodal way. And then patients unfit for surgery. So such patients who are, say, older age patient, diabetic, heart diseases, and due to some reason or comorbidity, they are not fit for surgery. So such patients are very ideal for pain management. Then coming to head and face area. We all are aware about headaches like migraine headache, tension headache. But in the international classification of headache society, there are almost 108 types of headache. Even I was shocked to read the classification. So these are so nowadays becoming super specialty branches, and we are not aware of so many conditions. I have listed here just for the sake of, making everyone aware that we have to look at different aspects or different point of view when the patient comes with headache and facial pain. Cluster headaches, cervicogenic headache, neuralgias like supraorbital, trigeminal, occipital, these are all originating from nerves. So as I said, wherever there is muscle or fascia, myofascial pains exist. And here you can see in this face, wherever there are nerves, there are chances of neuralgia, that is pain originating from that nerve. Then comes your atypical facial neuralgia, post-herpetic neuralgia, post-traumatic neuralgia, CRPS, or old terminology was reflex sympathetic dystrophy. Then temporomandibular joint pathology, it can give rise to different patterns of facial pain. Diabetic neuropathy, facial or glossopharyngeal neuralgia, or pains due to cancer related to, buccal mucosa, oral cavity, neck, or nasopharyngeal carcinomas. I purposely put this diagram. This particular patient of ours was having severe trigeminal pain. 10 days, she was groaning in pain. She was admitted with me. BP was 200 by 100. And I told physician that first you control the BP, sir. But then he particularly pointed out, madam, only during pain episodes, her BP shoots up. Then I said it is vice versa. Pain can give rise to hypertension, and hypertension can give rise to pain. So we need to rule out any medical emergency first. So we performed all scans for her, MRI, MR angio, and everything was normal. And I immediately took her up for trigeminal ganglion radiofrequency ablation. And see the smiling face after 12 days when she returned for follow-up in the OPD. I had never seen such a smile on her face before that. So I requested her, if you don't mind giving me the photo. And this was her smile. Then coming to neck pain. As I have mentioned, neck pain in this particular decade has become the disease of younger population, which was originally, it was quite commonly seen after 40s or 50s. But nowadays in the OPD, I am getting patients right from 14, 15 years of age, especially after COVID pandemic, because of online schooling or mobile handling or whatever lifestyle they have adopted. Again, poor posture, repetitive motions, degenerative disc diseases, neck sprain or neck strain, because of, everyone has got mobile in hand, and there are so many attractive apps and, movies, Facebook, WhatsApp, social media. And because this is so handy device, like I'm sitting in front of desktop and some sturdy device and table chair. So this is ergonomically correct position. But when device like this size comes in hand, it It's naturally wherever we are sitting or lying down, whether it is sofa, whether it is bed, and any position, we don't come to know that for hours together, my neck position is so awkward. And when I'm going to get sprain or muscle spasm. And that exactly happens when patient comes with neck pain or neck sprain. Neck injury, such as in whiplash, cervical herniated disc because of wrong posture, and this our habit is becoming like jaw is protruded. This is the wrong posture nowadays we are seeing very commonly on examination, giving rise to herniation of disc. Then cervical facet arthropathy. These are the facet joints we see. In these joints, because of loading of cervical facet joint, many a times we can feel the tenderness, and those are the areas from where pain can originate. And last but not the least, again, myofascial pain syndrome or fibromyalgia syndrome. Coming to chest pain. Whenever a patient with chest pain comes to OPD, whether acute or say history of few days or weeks, obviously, naturally, logically, I also evaluate this patient from cardiac point of view, because that is something life-threatening and warranting urgent attention. And after ruling out cardiac issues and gastrointestinal GI problems like acid reflux or other esophageal spasm-like conditions, then we can label it as chronic chest pain or atypical chest pain, which is not of cardiac or gastrointestinal or any thoracic origin. Reasons for this pain, for chronic pain management, could be herpes zoster, that is either just start of herpes, or it could be post-herpetic neuralgias. Very commonly we see intercostal areas or nerves getting affected. Then trauma, blunt trauma. Rib fracture. Rib fracture is quite acute condition, but sometimes fracture heals, or patient gives history like kaditari 6 महिन्यापूर्वी पडलं होतं पण तेव्हा काही झालं नाही, and now they have got pain. So sometimes in the history we have to really go back and dig it out. I always say pain management is purely clinical branch. Like in our training, we have been told we have to focus on history and clinical examination. So in pain management, 80 to 90% of the diagnosis is done in the OPD itself, and investigations have got only supportive role or diagnosis of exclusion. जसं की आपण म्हणतो, जसं पेशंटला आपण ECG काढला किंवा टेस्ट केली आणि ती नॉर्मल आहे, सो ओके, कार्डियाक प्रॉब्लेम नाहीये, एंडोस्कोपी ऑलरेडी करून आलेले असतात पेशंट, so GI problem nahi. And now then I am sure that this is atypical chest pain related to these pathologies. Then ICD, intercostal drain insertion or intercostal nerve entrapment. Many a times patient has history of ICU admission or some chest trauma for which intercostal drain was inserted few years ago. And then that time there was no issue. But over the period of time, slowly those nerves are getting stretched, inflamed, and now patient presents to the OPD. And that's why I repeatedly keep stressing on the part of history. Being medicos, it is very important to concentrate on history part. Surgery, again, intercostal incision for surgeries like pneumonectomy, thoracic surgeries, degenerative and malignancies, and metastatic ribs. Sometimes we have metastatic diseases, cancer, where we have rib lesions. And atypical chest pain. When all these pathologies, nothing can be found, we can't label it. It is called as atypical chest pain. Same is for abdomen. We know abdomen is a powerhouse of all organs. All major organs are sitting in the abdomen. And every organ has got their pathology. So like chronic pancreatitis, pancreatic pseudocyst, abdominal cancer, cholangitis, abdominal angina, urinary tract infection, endometriosis, chronic pyelonephritis, chronic pelvic inflammatory diseases, inflammatory bowel diseases, irritable bowel syndrome, uterine fibroids, again herpes zoster. So all these conditions, they have acute, chronic, on and off presentation, and they are quite well managed by surgical and medical fraternity by medicines. But sometimes they keep recurring, and then they have got limitations. Then we have specialized interventional pain management strategies where these conditions can be really taken care of well and patients are relieved of pain. And as I have mentioned here, the last condition, abdominal cutaneous nerve entrapment syndrome. Like I said, wherever there is nerve, there are chances of neuralgia, nerve entrapment. So in the abdomen, rectus sheath, there are minor nerves due to surgery or due to any other chronic illnesses. These nerves are damaged and they are giving rise to conditions called ACNES, abdominal cutaneous nerve entrapment syndrome. And then obviously we have to manage it in that way. Coming to limb pain, sometimes patient comes with the pain in hand or legs and swelling, like we can see in this diagram. Hyperhidrosis, they complain excessive sweating. So these are typically patients or diseases like CRPS, complex regional pain syndrome, type 1 and type 2. This whole topic is, big topic demanding separate lecture. Then Raynaud's disease caused by stable arterial occlusion. Frostbite sequelae, patient coming from, Arctic trips or sometimes even Himalayas. They might get some frostbite kind of picture. Diabetic neuropathies, long-standing, uncontrolled diabetes. Patient have, polysensory neuropathy, hand or legs, typically burning foot they come with. Then thromboangiitis or atherosclerotic occlusion with pain or limited tissue loss. We know sometimes patient comes with the gangrenous toes, either foul smelling wet gangrene or dry gangrene. So these are the patients which have got limited surgical role, but good role from interventional pain management point of view. Then post-herpetic neuralgia, phantom limb pain. Patient has undergone amputation, traumatic or surgical. There is no limb, but patient complains that part of the limb pains which doesn't exist. So these are the pains typically managed in chronic pain management. Whole body pain. Many patients come with this particular complaint that I have generalized pain all over body. हात पण दुखतोय, पाय पण दुखतात, अंग दुखतंय, डोकं दुखतंय, सगळंच दुखतंय. And it is our till now very routine practice to label it as psychological pain. But as our education has told us, in third year of MBBS medicine, malingering should be the last diagnosis for any patient. So that somewhere applies here. Diagnosing fibromyalgia is not very difficult, but only thing what mind knows, that eye sees. So जर आपल्याला माहिती असेल की असं काहीतरी आहे, एक्झिस्ट करतं बाबा, तर आपण त्या दृष्टीने इन्क्वायरी करतो पेशंटची आणि देन वी कम और इट हेल्प्स अस टू रीच द डायग्नोसिस. ओके, दिस कुड बी होल बॉडी पेन or fibromyalgia syndrome. Okay, so these types of pains are typically associated with irritable bowel syndrome, की पोटात गुडगुड होतं, कधी कॉन्स्टिपेशन होतं, कधी लूज मोशन होतं, असं काही फिक्स नसतं. डिप्रेशन, memory disturbances, restless leg syndrome. So these are very common accompaniment of fibromyalgia. Loss of interest. पेशंट विचारली हिस्ट्री की आतापर्यंत तुम्हाला काय आवडतं, हा टीव्ही बघायला, सिरियल बघायला खूप आवडतं, अँड दिस इज क्वाइट कॉमन इन फिमेल्स. बट रिसेंटली आय हॅव लॉस्ट इंटरेस्ट की ती पर्टिक्युलर माझी सोनीवरची सिरियल खूप फेवरेट आहे, पण आजकाल ती सिरियल लागली तरी माझं मन लागत नाही, मला असं बघावं वाटत नाही, इतकं अंग दुखत राहतं. So this is typical few points on history can immediately fetch us the diagnosis of fibromyalgia. Then coming to cancer pain. Cancer pains, कॅन्सर मध्ये टिपिकल बाकी जे पेन्स असतात ते आपल्याला माहितीच आहेत. एनोरेक्सिया, लॉस ऑफ ॲपेटाइट, कॉन्स्टिपेशन, ड्राय माउथ, इन्सोमनिया. बट इट हॅज बीन फाउंड दॅट पेन इज द कॉमनेस्ट प्रेझेंटेशन ऑफ पेशंट्स कमिंग विथ कॅन्सर. म्हणजे पेन झालं तर येणाऱ्या पेशंट मध्ये कॅन्सर डिटेक्ट होण्याचं प्रमाण 69% मध्ये इन कॅन्सर पेशंट. सो दिस इज द मोस्ट फ्रिक्वेंट सिम्पटम. So this can lead us to very, a crucial diagnosis in cancer patient and help us initiate early treatment. So that's why this symptom is really important and should never be ignored. And as we see, we all know cancer pain, we start with NSAIDs, opioids, chemotherapy, radiation, surgery, neuraxial blocks like some nerve blocks or spinal, epidural, and kadi IV medicines. And then comes the role of interventional pain management in terms of neurolytic blocks. And nowadays it is recommended by WHO that हे सगळं आपण bypass करून moderate to severe pain असेल तर कॅन्सर मध्ये आपण डायरेक्टली न्यूरोलिटिक ब्लॉक्स देऊ शकतो. लाईक आय हॅव गॉट फ्यू एक्झाम्पल्स. पेशंटना सिव्हिअर पेन असतो आणि दे आर नॉट रेडी टू अंडरगो किमो और रेडिएशन और इवन सर्जरी. दे लूज द होप की ठीक आहे आता कॅन्सर झालाय तर संपलं काय 2-4 महिने इकडे तिकडे बिकॉज ऑफ पेन. त्यांना वाटतं पेनच्या प्रपोर्शन मध्ये आजाराचं गांभीर्य आहे. And when we give them pain management, they are relieved so nicely. It is so gratifying. And then they have the hope for life. And then they undergo chemo and radiation. And then you know the life expectancy and result. It is wonderful. So this is how there are so many conditions, miscellaneous, chronic tingling numbness, herpetic neuralgia, post-surgical scar pain, post-surgical limb pain, edema, lymphedema, chronic disability consequences, sympathetically mediated pain, neuropathic pain. This every heading has got separate lecture. It is that big and vast. Then perianal or perineal pain. Okay. Patient complain की हा युरिनच्या जागी किंवा टॉयलेटच्या जागी दुखत राहतं, सुया टोचल्यासारखं दुखतं किंवा आगाग होते, जळजळ होते. So there are so many reasons for these types of pain and we really don't find it so easily. So these are the differential diagnoses like coccydynia, post-surgical thrombosis of veins, spinal cord malformation, sometimes failed back surgery. Spine surgery झालेली असते तर ते nerve entangle, scarring, fibrosis मध्ये epidural space मध्ये ते entangled असतात. Chronic testicular pain. So these types of pain we do come often in chronic pain OPD. Now, what is pain management? तुम्हाला सगळ्यांना वाटत असेल हे सगळंच तर आपण करतो. What exactly is different in chronic pain management as a specialty? So जसं की मी म्हटलं, understanding your pain, patient's pain, because this is very much based on history and detailing of symptoms. Okay, and as we know, pain assessment tool, this is very important to be implicate for every patient. I ask in every visit, okay, आता pain किती आहे? 7, 8, 9 आहे. Next visit, how much is the pain? So that helps us to keep a track to know how the pain is progressing or pain relief is gradual, and then to titrate the further management. Detecting pain generator. This is the terminology we use in pain management, that we have to finalize pain generator and then accordingly treatment is targeted. And lifestyle modification is really important part in pain management when it comes to conditions like neck pain, back pain, knee pain. Simple modification, behavioral strategies does help us to control pain along with medications. Next step, if all this doesn't help, is blocking pain generator. What we call it as diagnostic block with the help of local anesthetic. And if that local anesthetic injections, nerve injections, help us or patient to get pain relief, I know this is the pain generator. And after that, the most important phase is rehabilitation, because the pain has to be long-term relieved, and that is achieved only with the help of rehabilitation. So now I would like to draw your attention to this particular aspect. Pain has got multifaceted origin. So this is the definition of chronic pain. It has recently updated in 2020 by International Association for the Study of Pain. Pain is a distressing experience. Initially, they had said it is unpleasant, but now it is replaced by the term distressing. So it is really discomfort for the patient associated with actual or potential tissue damage. Like I said, दरवेळेला आपल्याला तिथे काहीतरी जखम आहे, काहीतरी इंजुरी आहे, ट्यूमर आहे, दिसेलच असं नाही. But it happens at the micro level. It happens at the tissue level with sensory, emotional, cognitive, and social component. So this is the depth of chronic pain problems. When pain persists over the period of weeks, months, and years, it definitely affects your emotional, cognitive, and social components. And that's why pain has got multifaceted origin: bio, psycho, social, and spiritual model. So this is the latest development in pain management specialty. that we have to approach and address the pain from all these four aspects: biopsychosocial, spiritual, matrix. That's what it is called as. So how do we do this? Like I said, non-pharmacological, pharmacological, and interventional pain management. And as we see here, rehabilitation is ongoing process. म्हणजे असं नाही की बाबा काहीतरी इंजेक्शन दिलं, ब्लॉक दिला कीच मग एक्सरसाइजला जायचं. So right from day one, when patient starts visiting, physiological and in select cases, psychological rehabilitation, psychotherapies, behavioral, cognitive behavioral therapies, coping strategies, positive feedback mechanism. I have got multimodal pain management clinic where I have psychotherapist with me, physiotherapist, nutritionist, along with all specialists like spine specialist, neuro specialist, ortho specialist. With in association with all, we can definitely take care of pain in a much better way. So like I said, non-pharmacological therapies like distraction techniques, whatever is your favorite hobby, like singing, walking, trekking. Then sleep, sound quality sleep is physiological antagonist of pain. So nowadays, because of stressful lifestyle, work pressure, work hours, even regular sleep is affected. So restoring that sleep is also important in pain management. Pharmacological management, as a doctor, we all know. Interventional pain management. Here comes the role of pain specialist. So we'll go now step by step. Like pharmacotherapy, we all are aware of analgesics, basic paracetamol or NSAIDs, muscle relaxant, centrally acting peripheral thiocolchicoside or baclofen. I mean, this is we routinely prescribe. Every one of us knows. So I have not given much of a stress on this part. We call it as co-analgesic like steroids, short-acting, medium-acting steroids like deflazacort, dexamethasone, methylprednisolone, and NMDA antagonist we use specially in pain management like ketamine. Anti-epileptics. So role of anti-epileptics like, sodium valproate, topiramate to some extent, like carbamazepine for facial pains, facial neuralgia. It helps. Antidepressants, triptomer. We all know patients are anxious. We write triptomer, Restil, anxiety relief, all medicines, zolpidem. We all are aware of these medicines. Only thing in pain management, we really titrate the doses and fine tuning is done so as to minimize the use of NSAIDs and steroids. In my last 8 years of practice, I have not written diclofenac to any of my patients. I'm using, advanced agents like etoricoxib or lornoxicam, piroxicam with better side effect profile, celecoxib nowadays we are getting. So these are the medicines with limited duration and keeping side effect profile in mind. Patients having diabetes, cardiac problems, hypertension, these are very important aspects in pharmacotherapy of pain because these are chronic pain patients. They keep coming repeatedly. So we can't keep prescribing the drugs just to get pain relief for months or years. Then is the role of opioids, mainly in cancer pain, right from weak opioids to strong opioids like morphine. Very limited role in benign pain. So coming to individual main treatment like back pain treatment, how we can treat, how we treat non-surgically who are unfit or unwilling for surgery with the help of epidural injections, facet joint injections, root blocks or dorsal root ganglion blocks, very selective, only sensory nerve component because it is giving rise to pain. We are not blocking motor component. Many a times patient comes with the anxiety. मग डॉक्टर तुम्ही ते इंजेक्शन देणार, तुम्ही सांगितलं नस ब्लॉक करणार, मग ते चालायला काही प्रॉब्लेम, उठायला काही प्रॉब्लेम, मग बधीर होऊन जाणार का पाय. So that's the advanced treatment and management. We are selectively blocking sensory component of the mixed nerve and not motor component. So various methods are used. And this is 90 years old patient who was unable to walk without stick or without support. He was having lumbar disc giving rise to pain in back and leg. And this video was recorded immediately 10 minutes after giving epidural for pain management. So this is the beauty of pain management. 90 years old patient, diabetes, heart problem, anticoagulants, can't undertake knee replacement surgery. And he was so happy since 2 years he was not able to go out of home alone, and now he is able to walk independently. So this is how the procedures are carried out with the help of advanced machines like radio frequency. This is cool radio frequency ablation, and patient is awake, patient is in prone position, and this is the modality for epidural C-arm guided in the operation theater under all aseptic precautions. Knee pain. Several patients again are not willing or unfit for surgery. So depending on grade of damage like meniscal injury, ligament injury, or osteoarthritis, there are various treatment options like viscosupplementation, platelet-rich plasma therapy, or genicular nerve radiofrequency ablation. So this is the platelet injection, and these are derived from patient's own blood. So this is natural source, autologous to patient, and no toxicity, no allergy. We perform under all aseptic precaution in the operation theater, and you can see just like giving local injection, this is the injection. Very commonly used in sports injuries like tendo Achilles, golfer's elbow, tennis elbow, knee osteoarthritis, shoulder, and conditions like this. So after knee PRP, so this patient was having pain since 2006, 16 years, and he was not able to go on a regular walk or play with his grandson. And this is how the result of platelet-rich plasma therapy has given him better quality of life. Like I said, cool radiofrequency ablation, this is the machine, and these are the needles. If we see these needles, there is no incision, there is no stitch, there is not even dressing after performing these procedures, done under local anesthesia. No need of fitness for the procedure. Patient is awake. I am continuously talking with the patients, and post-surgery, patients are immediately able to go for rehab. No bed rest and no, disabling days after surgery. Heel pain. Again, medicines, physiotherapy, and platelet-rich plasma regenerative therapy helps a lot. Frozen shoulder, very common after trauma or diabetes. In these also, nerve blocks, joint injections are performed with steroids, but with the advancement of platelet-rich plasma, I really don't prescribe steroids, don't give intra-articular steroids unless it is really pinpoint inflammatory condition. It is not required. So PRP therapy along with rehabilitation helps in faster and pain-free recovery. So this is the patient. We can see the movements. She was having history of trauma 3 months ago, accident, and this is the level of her shoulder movement. Left was better, right hand was absolutely hardly 20 to 30 degrees of range of movements, not able to do overhead abduction or even movement like putting hand at the back or wearing her clothes on her own. So this was very difficult without support. And this is immediately after the intervention in the OT table, on the OT table, because 3 months she was in pain and not able to move the hands. There was muscle weakness and atrophy, and you can see now she is able to. Okay, so these patients, because 3 months they have not used muscles and shoulders, they lose the confidence as well as there is muscle weakness. So after giving injection, we have to put them on rehabilitation and help them to carry out further exercises. Cancer pain management, I have already spoken. There are a lot of nerve blocks like celiac plexus, ganglion impar. Advanced treatment options, endoscopic surgeries for spine, vertebroplasty, single level vertebral fracture, we can put cement or metastatic vertebra. Intrathecal pumps, here we can see like chemotherapy is a pouch port asto, injection port. स्किन आणि सबक्युटेनियस टिश्यू मध्ये पाऊच बनवून ठेवतात. लाईक दॅट वी हॅव दिस इंट्राथिकल पंप्स रेझर्वॉयर केप्ट इन आयलियाक फोसा, आणि त्याचा इंजेक्शन पॉइंट वर मार्क करून ठेवतो. अँड देन वी पुट दिस पंप कॅथेटर इन द सबअरॅक्नॉइड, स्पायनल इंजेक्शन जिथे देतो तिथे हा कॅथेटर जातो. इट हेल्प्स इन क्रॉनिक पेन्स ऑर स्पास्टिक कंडिशन्स लाईक सेरेब्रल पाल्सी, स्पास्टिसिटी ज्याच्यामध्ये हातपाय हलवणं, स्ट्रोक, पोस्ट स्ट्रोक पेशंट, पेन, पॅरालिसिस, क्रॉनिक पेन पेशंट्स, कॅन्सर पेशंट ज्यांची थोडी लाईफ एक्सपेक्टन्सी बरी आहे पण पेन खूप सिव्हिअर आहे, तर तिथे आपण याच्यामध्ये मॉर्फिन, फेंटानिल असे इंजेक्शन्स रिफिल करू शकतो. दिस इज व्हेरी ऍडव्हान्स ट्रीटमेंट अँड इट हॅज टू बी रिअली मॉनिटर्ड क्लोजली. देन स्पायनल कॉर्ड स्टिम्युलेटर्स, समथिंग लाईक इथे दिसतंय हे लीड्स म्हणतात ह्याला. हे लीड्स आपण स्पायनल कॉर्ड वर प्लेस करतो इंजेक्शनने थ्रेड करून, लाईक एपिड्युरल कॅथेटर. जसा हार्टचा पेसमेकर असतो तसा हा स्पायनल कॉर्ड स्टिम्युलेटर म्हणजे स्पायनल कॉर्डचा पेसमेकर आहे. स्पायनल सेन्सेशन जी फिजिओलॉजी आहे इट इज कॅरीड इन द स्पायनल कॉर्ड. सो हा पेसमेकर इनिबिट करायचं काम करतो. So it stops or blocks the sensation at the spinal cord level. It doesn't carry sensation to our brain, and then brain doesn't give signals to body parts ki it is paining. So this is quite advanced therapy. Again, pains not responding to all previously discussed measures. This is performed spinal cord stimulator as a surgery and intervention together. Rehabilitation, very important post procedure. It need to be started immediately after pain relief. It has to be under guidance to avoid injury. Patient म्हणतात हो मी YouTube वर बघतो, मी रेग्युलर योगा करतो. That is not allowed, especially after the pain management therapy. It is done in the form of exercise or yoga or physiotherapy under the observation of expert. It helps in maintaining a longer pain-free interval. Again, this is the patient I saw just 10 days ago. Shoulder swelling, हे आजचा व्हिडिओ आहे. Shoulder has almost become half the previous. This was the fracture 10 years ago. This is the X-ray. This patient had this fracture 10 years ago and he was advised plaster. I don't know, there was some miscommunication. But he said की फक्त प्लास्टर घातलं, ते म्हटले थोडासा क्रॅक गेलाय. Later on, maybe movement or ignorance has caused this complete malunited picture जे आता आपण पाहिलंय. And 10 years patient is totally frozen shoulder, not able to move the shoulder. And now he's got severe pain. So just listen.
Voice is not clear, ma'am. It's
Okay.
not audible.
So basically he was saying that now he is able to lie down on that particular part. He was not able to sleep since 10 years on that shoulder. And now he is able to sleep on that side. And there is no pain only in 10 days of treatment. And now I have put him on rehabilitation today because he's pain-free. Now again pain will come. Rehabilitation is going to give rise to pain because this is immobile since 10 years. So now I have to put on some little, analgesic medicine. Again, as rehabilitation becomes little less extensive, I'll cut short the medicine. And his hand will start moving. त्यांना कपडे घालायला he used to need assistance. तर ते म्हणाले आज माझा मी शर्ट घालून आलो. So this is what we can achieve, small things in 85 years of old man. This really matters. So what is the advantage of this interventional pain management? This management is without surgery. It's a daycare procedure. All are image guided, either CT scan, CM, or sonography machine guided procedures. So they are very pinpoint and targeted. Shorter recovery period, patient is immediately discharged, no bed rest. They don't have to take sickness leave or absenteeism from work. Definitely they are safer as they are daycare procedures without anesthesia. They are cheaper. And most importantly, they can be done in patients with diabetes, hypertension, ischemic heart diseases. My oldest patient for spine was 95 years old, and he's able to walk on his own at this age. That is what is more than sufficient for him. So I would like to give this take-home message today that pain can be controlled if not completely treated. And that's why we always say it is pain management and it is not cure. So pain management, which is multimodal approach, it affects quality of life in a big way. And that's why interventional pain management is a vast new specialty that can help. So as this is the famous quote by Gautam Buddha, pain is inevitable, but suffering is optional. It's totally in our hands to undertake treatment. And this is the summary. I call it as pain pillet. We have to address and treat every aspect for pain management: cognitive, emotional, social, life stages, physical, comorbidities, body structure, function, ergonomics, and of course, genetics, which is under research. So thank you very much. Again, I would like to thank Association of NIMA. I have heard Nana sir talking a lot about the association and so many things you guys are doing. I'm really so proud of you all, working at grassroots level. And that's why I feel this particular topic should be at, provided and bring out to your notice. So everyone is aware that this is what is advancement and patients can be treated. So thank you very much.
Madam, thank you for informative lecture.
Thank you
Thanks
so
for
much, ma'am.
informatives.
It was really very knowledgeable session, ma'am. Can we take few questions?
Yes, sure.
Yes. And you gave really right message at the end. Pain is inevitable, but suffering is optional. Yes, everyone should keep that in mind. One question is, how many days the effect of epidural remains?
Okay, perfect. Very good. So epidural injections, as we all know, we give steroids, local anesthetic, and connective tissue dissolver. So once that is put in there, it acts in both ways, like taking care of inflammation, which is chemical action, and mechanical action, like breaking the adhesions and bonds. It's kind of, छोट्या छोट्या त्या आत जखमाच असतात ना, स्कारिंग होतं, फायब्रोसिस होतं, अधेजन्स होतं, आणि डिस्कम्प्रेशनमुळे, नर्व इन्फ्लेमेशनमुळे. आणि त्याच्यामुळे when we put these injections, it dissolves mechanically as well as chemically. And after that, most of the time what people do ना, हे सगळीकडे खूप कॉमन आहे की एपिड्युरल घेतला आणि घरी बसले. And that's why everywhere I stress the importance of rehabilitation. Epidural works at spinal level. But over the period, because of pain, your paraspinal muscle, your facet joint, your musculoskeletal alignment has changed. And that's why when you put them on physiotherapy, in last 8 years, I think माझे एक का दोनच patient epidural ला परत आलेले. So this is once and all therapy, if you take care of every aspect of it. Okay.
Okay. One more question: how to treat fibromyalgia?
So fibromyalgia has got medical management. Basically, fibromyalgia साठी आपण जे SNRI, serotonin norepinephrine reuptake inhibitors म्हणतो, that is the first line drug. Okay, duloxetine, gabapentin, venlafaxine. These are the first line drug. It is medical, and we have to really take care of psychological aspect of this patient. Secondly, physical therapies like aqua therapy, swimming, exercising. Because you get typical history from this patient. This pain is aggravated with rest. And as their day starts, सकाळी फ्रेश वाटत नाही, उठल्यावर कसं तरी वाटतं आणि काम करायला लागलं ना की दे फील बेटर, पण बारीक पेन्स राहतात. So then at the end of the day, if you ask them to take, hot water shower, bath, and some regular exercise, which they are acquainted with, that is advisable. Shweta ma'am, can you put some more light at this particular aspect? You are on mute. Acha, they have to unmute you. Okay.
Yeah, I'll do that.
Prerna madam, you ask on behalf of her.
No, I'm just trying to unmute her.
It won't be, madam. It won't be.
Okay, fine.
She's not host. Okay.
You present the question. No problem.
Yeah. Can we take another question, ma'am?
Yes, please.
Yes, sir. Yes.
Yeah.
Is it satisfied or whatever I told?
Yes, absolutely, ma'am. We'll just take a last question, I guess.
Right.
Or one more question. Last two questions only. Multiple sclerosis pain management.
Okay, so these are all, multiple sclerosis and diseases related to cervical palsy or chronic central nervous system related diseases like post paralysis pain or spasticity. So these are type of pains which have more of a muscle involvement. And then we have treatments like needling, or which I have mentioned, intrathecal pumps when there is spasticity. So, diseases might be same, like you might have 10 patients of multiple sclerosis, but pain generator will be different in every patient. Okay. So some patients have what we call it as central pain. Some patients has spasticity related pain. Some patients has neuralgic pain. So depending on pain generator, management will vary. So whatever all modalities I have mentioned, any modality can work in this type of patient also, depending on what pain generator I find. How long pain remains after muscular tear? Muscular tear will give rise to acute pain, and it will last and it will keep coming, especially like shoulder and knee, because your shoulder and knees are not going to be stable. These are the joints which are constantly in motion. So over the period, that will form fibrosis and thickening, and that will lead to dystrophy or atrophy of the muscle and slowly giving rise to frozen shoulder. So at one point, your pain might vanish because there are no more painful nerve endings. They're fibrosed and scarred, but that will give rise to loss of function. Okay. So earlier the management better, because over the period, it involves other components of the joint also. So after some time, you might feel, okay, आता pain थांबला म्हणजे आता आजार बरा झालाय. But it is probably आपण म्हणतो ना वादळापूर्वीची शांतता. So तसं काहीसं असू शकतं. Prerna ma'am, can I request you, because Shweta ma'am is a chairperson, so she has to complete.
Yes, actually, can technical team unmute Shweta ma'am, please?
And I would really like to listen to her insights.
Yes, we are going to listen to her.
She's going to definitely add much more.
Yes, absolutely. Can technical team unmute Shweta ma'am, please?
Yeah, I think I'm being unmuted.
Yes.
It was a great lecture, Dr. Varsha. Absolutely extensive, comprehensive review of understanding of pain, approach to pain, and pain management. Because management, even as doctors, so far we were under the impression it is always the diclofenac injections, either paracetamol or diclofenac. That's the maximum. And there are so many patients who come who are on chronic NSAIDs, and they'll end up with kidney disease, and pain is still there. So the side effects of these medications we have understood, and that's the reason we go on to the interventional pain management, where the drugs that we use, the blocks that we use, and the other modalities that we use have less of these side effects, and it addresses just not the neural component, but also the ligaments, muscles, tendons, everything is taken care of, because whenever there's one part that is affected, the others get secondarily involved. And that is the reason we have to address it, the entire joint, rather than just looking at just the muscle or the ligament. And most common pain that we have seen, or what we know, are the acute pains, the post-surgical pain. And even acute pain, if it is not treated properly, that is what it leads to increased incidence of chronic pain. So during the surgery, we should be very much careful of taking care of post-operative pain, because if that is not taken care, most of the patients, a huge number of population, do develop chronic post-surgical pain. So there are so many things which are there in our hand, and we should be able to kind of take care of it by addressing these small issues. Now, she has very well said, Varsha has always said, that pain is multidimensional. It's just not the physical component. आता तुम्हाला मार लागलं, समजा तुम्हाला गोल्ड ब्लॅडर सर्जरी केली, मला गोल्ड ब्लॅडर सर्जरी केली, आपण दोघांना सेम पेन होणार नाही. The type of pain, the severity of pain is going to be very, very different in you and me. And it will depend on so many other factors, which she has already said, right from your beliefs and cultural practices. Manje, we have seen so many photographs, people do so many piercing here and there, and they don't have any pain. And we look at them and say, oh my God, what has she done and what has he done? But that is what the belief that person has, the cultural practices they have, the spiritual alignment that they have. So there are so many factors that affect the perception of pain. Even if the injury is same in two people, the perception of pain is very, very different in two individuals, because it depends on so many other factors. And that's the reason the pain management addresses not only physical dimension, but all the other non-physical dimensions of the pain. And it's very important to then go ahead with the multidisciplinary approach, as Varsha said already, by going step by step, non-pharmacotherapy, pharmacotherapy, and interventional pain blocks. Or if the pain is severe, you may start the other way around. Simultaneously. It's a horizontal approach. You start with everything, but at the same time, you also give the block for the immediate pain relief and patient cooperation. So why do we need to treat pain? Because if we don't take care of this chronic pain, it's going to be debilitating disease. It's a disease. It's not a symptom. So we have to remember that it's going to affect the quality of life to such an extent that we are not adding any years to that person's life. So it's very important that we do multidisciplinary pain management so that we can improve the quality of life, reduce the side effects of the dysfunctionality, and improve the quality of life. And that's why I say that pain relief is a basic human right. Nobody should be suffering, even if all of us, pain is inevitable. All of us are going to suffer from pain sometime or the other, but definitely we can manage it well so that it does not affect our day-to-day life or our social life or our professional life, and we move on with whatever we have. And Dr. Varsha has put up everything together very well for people, and people are asking so many questions. I'm seeing they realize the kind of difficulties they have gone through. All of us have gone through some chronic pain sometime or the other, and those personal questions have started coming up, that I have this problem. So I'm happy that the pain awareness is happening about the management, and it's important that we have been able to kind of, put it across through people, the importance of the pain management. Thank you so much for giving the opportunity.
Thank you so much, ma'am. Thank you so much. And it was really very knowledgeable lecture by Dr. Varsha Kurade. It gave us
Dr.
different...
Prerna, please, one moment. One thing very important I would like to highlight, just reading questions, I realized See,
Yes.
every pain problem or pain condition gets aggravated by any systemic illness. Like someone asked about restless leg syndrome. So if you have, say, diabetes, hypertension, kidney problems, cerebral problems, and they are not under control, pain condition gets aggravated, hypothyroidism. So it is very mandatory to take care of your primary disease and continue that treatment, keep a track with your primary physician. And once they are all under control, then pain management starts and works very well. So that is very important to rule out any systemic conditions. If it is there, just check whether it is under control, all thyroid levels, your diabetes, sugar level, BP is under control, and then our pain management works wonder. So sometimes the reason of failure, no, someone asked epidural and all. So that is also reason to fail. And that's where, we get the interpretation that this is temporary, No, ma'am has been practicing this since 15 years, more than 15 years, I guess, till I left KU. And then I'm here since 8 to 10 years. And we have seen our patients getting permanent reliefs from those conditions once we address it as a whole, patient as a whole, and not only leg pain or back pain. So take care of his body and other conditions as well.
I would just add, just not body, but mind.
Mind, yeah. Body and
mind. Very important. And that counseling, ideally the team should have a psychologist, a clinical psychologist who can address these issues. But many times in India, we don't have so many clinical psychologists, and it's not preferable to send them to psychiatrists because there is no disease as such. You just require a little bit of correction of thoughts that you have it in mind. So psychologists are the ideal people. We should have it in our team. If you don't have a psychologist, you do the duty yourself as a pain physician. And it's very important to do that, but it is extremely important. The emotional and psychological and socioeconomical components both have to be taken care, but body, mind, both are important. They have to be aligned to get a little better outcome.
Yes, perfect.
Thank you so much, ma'am. Thank you so much, Sweta Salgaonkar, ma'am, for your guidance. And this holistic approach towards pain and this awareness lecture today, it was really important to think in different perspective about pain. And this holistic approach means this physical, mental, and spiritual. So this was really different perspective we got today. Thank you so much, Varsha Kurade ma'am, for your knowledgeable lecture. Now I invite Dr. Narendra Kasbe sir, Nanded Division Secretary, NIMA Maharashtra, for vote of thanks. Dr. Narendra Kasbe sir. Please unmute yourself, sir. Dr. Narendra Kasbe sir.
येस आवाज येतो मॅडम?
Yes, yes, sir.
येस. निमा महाराष्ट्र स्टेट ब्रांच यांच्यातर्फे ज्ञान यज्ञ शाखा ही जी सिरीज वेबिनार सिरीज चालू केलेली आहे, त्या वेबिनार सिरीज मध्ये आज सर्वप्रथम मी मॅडम वर्षा कुराडे मॅडमांचं खूप खूप धन्यवाद करू इच्छितो, कारण की त्यांनी एवढा किचकट विषय आम्हाला फार सोप्या भाषेत समजावून सांगितलाय. इव्हन त्यांनी फार छोट्या छोट्या गोष्टी, अॅक्यूट पेन, क्रोनिक पेन, रिझन्स ऑफ पेन, पेन सायकल आणि हेड पासून टो पर्यंत प्रत्येक पेन कसा असतं आणि त्याची ट्रीटमेंट काय करावी, फार्माकोलॉजिकल पेन, नॉन फार्माकोलॉजिकल ट्रीटमेंट, या सगळ्या ट्रीटमेंट, इंजेक्शन्स, या सगळ्या इतकं सविस्तर सांगितलेलं आहे. त्याबद्दल मी त्यांचा अत्यंत आभारी आहे. त्याचबरोबर निमा सेंट्रल ब्रांचचे अध्यक्ष आणि कोषाध्यक्ष टेंभुर्णीकर सर आणि आशुतोष कुलकर्णी सर यांचा नियमित आम्हाला सहकार्य लावत असतं, त्यांचाही मी आभारी आहे. त्याचबरोबर या वेबिनार सिरीजची संकल्पना आणि सुरुवात करणारे आमचे स्टेट ब्रांच यांचे अध्यक्ष सुहास जाधव सर, कोषाध्यक्ष भूषण वाणी सर, सचिव आणि बाजारे सर यांचा सुद्धा मी आभारी आहे. त्याचबरोबर जी वेबिनार कोऑर्डिनेटर टीम आहे डॉक्टर विष्णू बावणे सर, पद्मवान केसकर सर यांचाही मी आभारी आहे. त्यासोबतच ही सगळी सिस्टीम राबवण्यामध्ये आणि प्रत्येकाच्या टेक्निकल अडचणी दूर करण्यामध्ये जी आपली टेक्निकल टीम आहे ते डॉक्टर मनीष जोशी सर, गिरीश डागा सर, प्रशांत खोसे सर यांचाही मी आभारी आहे. आणि या सर्वांसोबतच सेंट्रल ब्रांच, स्टेट ब्रांच, वुमन्स फोरम, स्टुडंट फोरम या सगळ्यांचे एक्झिक्युटिव्ह, ऑफिस बेअरर्स, सर्व पदाधिकारी यांचा आभारी आहे. आणि या सर्वांना सुसंगतरित्या एकत्र जोडणे आणि सुसंवाद करणे प्रेरणा मॅडम यांचाही मी धन्यवाद करतो. आणि जय निमा, जय महाराष्ट्र. थँक्यू.
Thank you so much.
Not to forget Salgaonkar madam for her kind remarks
For her
and
guidance, right.
Borse sir also.
चेअरपर्सन श्वेता सालगावकर मॅडम आणि नंदकुमार बोरसे सर यांचाही आभारी आहे. आणि सालगावकर मॅडमनी ज्या मला आणखी आमच्या ज्ञानामध्ये भर टाकली आहे. आणि सालगावकर मॅडमने एक टॅगलाईन खूप छान वापरली, पेड रिलीफ इज अ बेसिक ह्युमन राईट. थँक्यू मॅम.
Yeah. Thank you for the opportunity. We are very happy that I'm sure there has been some awareness among a lot of physicians, and so not only them but their patients will get benefited definitely, I'm sure.
Definitely, ma'am.
Yeah.
Thank you so much.
Thank you. Yeah, thank you all.
So, with the permission of NIMA MSB PST, can I declare that we have concluded today's webinar? Dr. Suhas Zadav sir.
Yes, madam. Thank you very much.
Yes, thank you so much all for your patient listening. Thank you so much.
Thank you very much, Kurade madam. Thank you very much, Salgaonkar madam. Thank you very much, Borse sir. And not but never the least, Prerna madam, who took everybody in a very good spirit. Yes. Thank you, everybody. Thank you.
Thank you, sir.
Thank you. Bye-bye.